Hello, everyone, and welcome to the discussion on air and surface cleaning technologies for indoor environments. We're honored to have a distinguished panel of experts with us today. They will share their own findings and experiences, as well as the strategies and technologies they are leveraging in their facilities. So let's meet our panelists. First, Nick Highsmith. Nick is a pediatric infectious disease physician serving in a number of key roles. He is the medical director of infection prevention for Le Bonheur Children's Hospital. Additionally, he serves as medical director of associate health at Methodist Le Bonheur Healthcare and sits as system chair of pediatric medicine. Mary Margaret Phil is deputy state epidemiologist for the state of Tennessee. Since January of 2020, Dr. Phil has served as the leader of the state of Tennessee COVID-19 task force. Scott Cummis is the ex-chief of clinical services to the White House and the first board-certified occupational medicine and aerospace medicine physician to ever serve in the White House. Chad Call serves as clinical assistant professor, Uniformed Services University of Health Sciences at Walter Reed. Dr. Call leads the Surface and Airborne Hazard Task Force, a think tank including bioenvironmental engineers, microbiologists, infectious disease physicians, and senior aviation pilots. Dawn Gamera is manager of infection prevention at Le Bonheur Children's Hospital. Dawn has been practicing infection prevention and control for more than 25 years and is certified in infection control and clinical research. He has been distinguished as a fellow from the Association of Professionals in Infection Control. And Rasha Hassanin will be our moderator today. Rasha is the Executive Director for Trane Technologies Center for Healthy and Efficient Spaces, which convenes leading experts to advance indoor environmental quality policy, strategies, and solutions, and establish roadmaps for more resilient and sustainable communities. Rasha also leads innovation for Trane Technologies. We thank you all for your time and for sharing your expertise with us today. With that, let's turn to Rasha to get the discussion started.
Thank you all for joining us today, and thank you for submitting questions in advance. We'll be addressing some of these questions today, and if we don't cover a specific question or we're not able, you didn't hear sort of the answer you wanted, someone will follow up with you personally after the fact. You know, our world has changed dramatically over the past year. COVID-19 has caused over 500,000 deaths in the U.S. alone. It's shuttered businesses and schools. It's overwhelmed healthcare facilities, and it's upended the daily lives of millions of people globally. Facilities of all types, be it a school, a hospital, a business, a manufacturing facility, have had to shift the way they operate and find innovative ways for keeping individuals who frequent them safe, whether that's employees or customers or patrons. As the scope of the pandemic became clear, there was a mad rush to secure technologies that could potentially mitigate infection risk, whether it's within a building by supplementing their existing surface or air cleaning and disinfection procedures, or within a specific space in order to be able to secure employees and patrons. For many facilities, choosing the right solution has been a trial by fire experience, not just from an infection control perspective, but also from an operational and logistical perspective. As a result, there's been a number of lessons learned. Today, our panel of speakers is here to share their experience in managing COVID-19, in applying CDC and best practice recommendations, in reducing environmental exposure risk from the virus, and in implementing some of these strategies in their own spaces. At CHES, we aim to engage leading experts for their insights and opinions. Neither Trane nor Trane Technologies is directly affiliated with these panelists. Our goal with this event is to really educate the market and really raise the understanding around COVID-19 and virus transmission risk. As you heard in the panel introductions, our speakers have a wealth of experience and expertise. We're honored to have them provide their insights into everything from the current state of the pandemic to the role of environmental technologies that supplement or augment standard cleaning and disinfection practices, to reducing infection transmission risk, to other key factors that they use in assessing those different supplemental, or as they're often called, adjunctive technologies. They'll additionally share their experience in implementing the technologies and their thoughts on how these technologies fit into a comprehensive approach to keeping an environment safe. So let's dive right in. Dr. Highsmith, would you please provide us with the current state of the pandemic? Maybe give us an overview of how we're doing, what's going on. We'd really love to hear your thoughts on the need for enhancing technologies that can be used above and beyond standard cleaning methods. In other words, why are some of these technologies necessary?
All right. Well, thanks everyone for having me. Thanks everyone who's listening in. Thanks for being here. Just to give a quick state of the pandemic, and then I'll dive into some of those questions that were just raised. So I think just to start off, I would like to say that I'm a bit encouraged at this current time with the state of the pandemic. If we go back and look at where we were approximately 1 year ago, it's kind of hard to believe it was about a year ago that this all started. You can see that early in the year last year where we were, and then we had that peak just in the summertime, just before the summertime. And you can see on this graph here, this is actually showing total deaths with a 7-day average, and then total deaths with the blue bars there. This actually mirrors very well the cases, the new cases throughout the United States also. So you can see that we had that peak in the summertime, and then everyone put all the measures in place: social distancing, masking, restaurants closing, that sort of thing. We all implemented the CDC guidelines well then, and sort of mitigated the continued rise in that, and then it sort of slopes down. And then we see what happened towards the end of the year in December, November and December, where we saw a peak after Thanksgiving, where a lot of individuals we hypothesized were gathering together to sort of celebrate that time of year, and the same sort of thing with Christmas. Well, it's been really encouraging, and this, like I said, this graph also mirrors very well the number of new cases throughout the United States, is that since the first of the year, we've seen this sort of pretty dramatic, first off, and then continued gradual decline of new cases of COVID-19 as well as deaths. We've seen the hospital pressure, at least where I am in the southeast United States, we've seen the hospital pressure decrease. So our hospitals haven't been as full of critically ill patients with COVID-19. And we think a lot of that is due to continued measures of social distancing and masking, but also starting to see some effects of the vaccine rollout, especially in our healthcare workers, our providers, and our frontline workers. We've seen a pretty dramatic decrease in the number of our healthcare workers and the frontline staff who have been off due to COVID illness over the last month and a half since we've started to roll out the vaccine at the end of the year. So that's very encouraging. I think that there are a lot of reasons for us to be happy moving into this new time as we move into the rest of the year. I think there are still some questions out there, which I'll cover in just a second. I think we do know that there are these variants that have begun to crop up. So the UK variant is the one that we're sort of most attuned to right now. We've seen the most cases of the UK variant across the United States. We're also seeing this South African and Brazil variant, which you can see there on the slide. Now, I think that we are not surprised that we're going to see the majority of our cases sort of switch over to this UK variant, and we've started to see some of that in the sequences that we've done here in Memphis. I suspect that's probably the case for a lot of the rest of the country, and then isolating some of the South African and Brazilian strains as well, and just sort of seeing how the severity of the disease might change with these new variants, and knowing that it looks like our vaccines will be effective against the UK strain for sure, and then somewhat effective against the South African and the Brazilian strain. So I think I would say the state of the pandemic is improving. I think there are some questions out there that we're still going to watch very carefully. We were all excited to see the new guidelines from the CDC regarding those of us who've been vaccinated and and the ability to see some other vaccinated family members and that sort of thing that a lot of people have been waiting on for some time. So that's sort of the state of the pandemic. I think that I'll say when discussing new technologies, as medical director of infection prevention for a rather large hospital system, I very frequently have to look at new technologies and evaluate them to sort of augment our infection control practices. And I think that, as you've said already, no technology can replace the day-to-day human cleaning of the environment. I don't think anybody would be a proponent of that, but I think that new technologies can definitely augment the things that we are doing to help sort of fill in the gaps along the way and fill in areas where there might be some missteps or human error along the way. And I think that's really important. And that's what I try to do when I look at new technologies. I think that with emerging infections and new disease processes, that we have to continually look at different ways to combat those. And COVID-19 is a perfect example. Prior to COVID-19, airborne isolation was something that was typically reserved for, patients who were coming in with possible tuberculosis, or on the pediatric side with measles. Wasn't something that you would have to be concerned about overrunning, your emergency department or, a unit in your hospital. So it's definitely caused us to look and think about other ways that we can mitigate airborne spread of certain pathogens, of certain bacteria and viruses, and to look at different technologies that would help us to achieve that. And then I think that there are a lot of technologies out there, and I think that just evaluating how those fit into your operational plan, how they work with your hospital facility, and making sure that those are evidence-based products is very important. And it's just a very exciting field and an exciting time with these new technologies.
Awesome. Thank you, Dr. Highsmith. Maybe let's turn to Dr. Phil. Dr. Phil, you've got a lot of hats. You've got a really kind of impressive background. As you're deputy state epidemiologist for the Tennessee Department of Health. You're a board certified physician and a former epidemic intelligence officer. I didn't realize there was a thing with the CDC. So you have a really unique perspective on the environmental challenges posed by the pandemic. Maybe you could speak to how you and your colleagues in other states are addressing the many changes that are coming from the CDC guidelines, and particularly as they relate to environmental transmission risk.
Sure. Well, thanks for having me, first of all. I think it's surreal in many ways to think back and realize that we've been dealing with COVID-19 for over a year now. We just passed the anniversary of our first case being diagnosed in Tennessee on March 5th, so just over a year. And there's really a lot to reflect on, particularly when we think about how far we've come and how much we've learned in this last year. And so I have just a few key points that I'd like to highlight, and I'm going to piggyback on a couple points that Dr. Highsmith made. But first, I think it's just important to remind ourselves that this is a novel pathogen. Coronaviruses are not new. Pandemic coronaviruses are not new, but SARS-CoV-2 is a novel pathogen that until the end of 2019, more than likely, was not known to cause disease in humans. And it takes time for us to learn about pathogens, and that knowledge is going to evolve over time. So I've been I think as a professional in my role, so impressed with how quickly we've accumulated knowledge, how quickly there's been the identification of new ways to mitigate transmission of this virus in a variety of different settings. We've seen impressive work by epidemiologists and coronavirologists and aerosol scientists and environmental engineers and many others. And that body of work, I think, has really helped us come to a much better understanding now, 1 year later, of what the greatest risks are for transmission of this virus and what measures need to be put in place to try to control that spread. I'll also say, and again, to sort of continue on a thread that Dr. Highsmith mentioned, is that, we often think in absolutes and understandably rely on our past experiences. I think throughout a lot of this, we want to compare this virus to a virus that we know and understand. We want to lump it into the bucket with influenza or into a bucket with measles, or think about it in terms of contact transmission, like the common cold or like C. diff, and think we know how to control X, Y, or Z pathogen. Let's put SARS-CoV-2 into that same bucket, and then we'll know what to do. And the reality is that that's hard to do, and I think it's led to frustrations by some people, and especially in the professional community, and perhaps particularly in the healthcare community, as certain terms and phrases are used to describe transmission of this virus that, sort of automatically put it into one of those buckets of one of those other pathogens, when in reality, that's not entirely the case. And so I say that simply to say that it's human nature and it's understandable that we do that. But I think there's been a lot of confusion and perhaps confusion in terminology, as we think about appropriate infection control precautions, appropriate mitigation measures to take by using terms that we associate with certain pathogens from our own, knowledge and training and experience. And so sort of going back to point one, this is a new virus. And so we have to think of it in a slightly new way as we've learned about it and learned, on the spectrum of risk, where certain activities or procedures or other measures fall. And so, I think the other point to make is that transmission is very complex. We all want to know, how do we decrease our risk from, the grocery store clerk to the critical care doctor and everyone in between. Their levels of risk are highly variable and very different depending on what they're doing. Transmission is dependent on viral factors, how the virus transmits, in its own behavior and sort of basic science principles. It's also dependent on host factors and that host-virus relationship, on, how infectious is a person at a certain day, what factors of particular people who are infected make them more infectious than some other people may be. We've learned much more in recent months that setting is so incredibly important about transmission. We know that crowded and inadequately ventilated spaces are much higher risk for transmission. It's, both the context of where you are, as well as the intensity and duration of that exposure that impacts transmission. Whether you're indoors or outdoors, whether there's adequate ventilation or not. And exactly as others have mentioned, all of those factors have to be taken together to understand, the highest risk and lowest risk and what steps can be taken to try to drive particular environments down lower on that spectrum. And then, of course, considering any mitigation measures that may already be in place, be that masking or ventilation requirements, or if you're in a hospital, being in a negative pressure room, whatever those measures may be that already exist, they're already impacting the risk of transmission. And then I think, the other perhaps elephant in the room a bit is that as much as we've learned about the science of this virus, we have to then apply that in the context of the real world. We've seen very early on in the pandemic substantial limitations in personal protective equipment for healthcare workers. We see COVID patients being cared for in settings that don't have access to negative pressure rooms or full airborne isolation precautions, perhaps. And so, trying to then take the basic science understanding that we have of this virus and apply it to the variety of settings and practices and applications where people are professionals or just human beings or interacting with others who are infected with this virus is important. And I think that's also probably been a point of frustration for some people in applying, the purest and most rigorous standards to the real world and how we accomplish that as safely as possible. So, in thinking about how we've approached that in our state, I think we recognized early on that things were going to change over time. This was not going to be in March of 2020 that we would have all the answers about this virus. And so we've tried to set that expectation both with the general public and with professionals, be it in industry or healthcare or commercial settings, as much as we can, and really just be good
mediators and communicators about changes and updates and guidance from CDC or APIC or others as we update our knowledge with the best available information that is there, and as we learn more and further refine the best approaches to take regarding mitigation and decreasing transmission risk. So, I think we're fortunate to have a pretty robust team of infection preventionists in Tennessee that's worked really aggressively, especially with our healthcare partners that may not have as much IP expertise to bridge that gap. And then to try to also, be facilitators of that information to non-healthcare settings to the degree that we're able to. But I think, the fact that things have changed and evolved and that we learn more and there are new technologies available is fully expected. And I think we should really embrace that opportunity to further refine our ability to decrease transmission in combination with vaccination and masking and all the other prevention measures that have been so effective. The fact that we have other opportunities to continue to decrease transmission risk for this virus in a variety of settings is exciting. And as we grow our evidence base, both about the virus and different mitigation opportunities, I think it's an exciting time. And I think a lot of us see really a glimmer of hope in the pandemic for the first time in a long time that we're hoping will continue on in the coming months and years.
Awesome. Thank you so much, Dr. Phil. And no truer words were said. It's absolutely some of the most complex science out there. I mean, it's sort of this chaos theory of, the carrier and the host and the setting and the complexity of the airflow and all of those things coming together. And this concept of having a multi-layered or multiple venues to battle the pandemic is absolutely very critical. The concept of not having a silver bullet is something people are just going to have to contend with and start to look at solutions. And, just building on that, there are so many different supplemental technologies out there in the market. And maybe what we can do is shift gears and talk a little bit about, an approach to differentiating among the options that are out there. Maybe we'll start with Dr. Cummins and then go to Dr. Call on this one. But maybe you both can tell us in your kind of what you used when you were reviewing these technologies and looking at all of the available options out there. What metrics were you using when you were looking at them? What were you thinking about from an operational or logistical standpoint? And what do you see are the most important factors that somebody who's considering the sort of the variety of technologies out there, what should people be looking for? What factors should they take into account? What barriers could they overcome? Maybe just relay your experiences to us. Maybe let's start with Dr. Cummins and then follow up with Dr. Call on this one.
Great. Thank you so much. I really appreciate an opportunity to speak to all of you. As a former military person, everybody said to us, thank you for your service, but I really think that's an important way to start this conversation. Thank you very much that work in the education area. 18 years of my life, I spent time with you, and I really appreciate your service. So when the first thing I was thinking about is when I worked at the White House was how to prevent sick days for the White House staff. Because, of course, what we wanted to do is to be able to maximize the staff availability and capability. And, of course, the number one reason why we worked at the White House is to protect the health of the president. So that was kind of the initial way that I started thinking about this. On top of that, one of the important things to think about this is safety. As doctors, when we think about technology and stuff like that, we don't want a technology that could potentially cause damage to a human. So we look at things like the OSHA requirements, patents, and all that other types of information. I also looked at certain things that not only protected humans from infections, I also was looking at things that are part of building health and safety and wellness plans. So I think it's one of the great things is that the facility managers are part of this conversation today. That's been a key part of my experience. Also wanted something that could take care of not only surface germs and viruses, but of course, and important in the COVID era, airborne germs and viruses. So one of the things that I typically do is, or one of the ways I kind of, when I'm sitting face to face with an individual, one of the things that I talk to somebody about is, imagine you and I were not wearing masks and I coughed at you. One of the neat or amazing things about the dry hydrogen peroxide is that it immediately, I call it, attacks or reduces the airborne virus before it reaches the other individual in the room and before it reaches the HVAC unit. So we'd always say that HEPA does work, UV lights do work, but the germ or virus needs to reach the HVAC system in order to reduce or kill the germ or virus. So I think it's also important to think about is that this type of technology, the dry hydrogen peroxide, they're both portable units and there's HVAC units that are attached to the HVAC unit. So it's a very kind of hybrid concept of how you can select the technology. One of the also more important things is, in my experience, a lot of people said, well, I mean, do we have to cover a whole building? I mean, but the answer, in my experience, is no. You can select certain key areas of the room where there's less social distance, like locker rooms, cafeterias. You can cover the hallways. And don't forget that even though those are, say, the main covered areas, the dry hydrogen peroxide will still flow into the different rooms and areas in the building. I think I'm going to turn this over to Chad for Dr. Khan for him to add additional information.
Hello, everybody. So I just wanted to say thanks to everyone for hosting me. It's a great collection of colleagues here. It was a great introduction from Nick and Mary. Of course, I know Scott very well. We've consulted together, and I also knew him in a good group of academics here. When I noticed Mary has a photographs along with her family, it looks like she's got Ebola virus pictures behind her in her office. So yeah, Scott and I share in common. We both have deployed as aerospace flight surgeons in Iraq and Afghanistan, and I think our thinking as physicians on this perspective is, how do you take these what have historically been in vitro studies, meaning it's been explored in the lab, and apply them in vivo, like as we have sat down with the Bowser administration here in DC, and both have consulted the White House on these matters, as well as the Department of Defense, and a multitude of institutions that, even as the pandemic winds down, will continue to have significant exposure concerns. I would point to the fact that, as Eric was saying, that the percent positives and the deaths have continued to fall. But of course, the unknowns are the variants and how infectious those variants will be. And from large institutions like governmental institutions like the White House or the Department of Defense, how do we look around the corner and protect vulnerabilities with adding some of these synergies that are well tested? And I think, again, after exploring a lot of these technologies, I think the two basic ones, as you'll see in the slide, are either episodic or kind of automatic or continuous. So episodic would be, cleaning and touchless surfaces and Purell and masks. And then these more automatic passive technologies, kind of broken down into photocatalytic oxidation, bipolar ionization, the dry hydrogen peroxide or molecular gas hydrogen peroxide molecules, photocatalytic oxidation, and then kind of the newest one out of Columbia being the far UVC in the 222 nanometers. Those are kind of the big five that we've looked and explored. And I think no matter what of those five technologies, you're comparing them against the story technologies of what ASHRAE considers right now being what they're willing to go out on the line and saying there's clinical evidence to support enough clinical evidence to support this technology taking the next step and saying, is ventilation what ASHRAE is getting behind? I think that's been their stance as far as how to remove virus and bacterial particles from HVAC systems. So when clients come to me as a physician to say, what is currently been approved or what's on the table, and you can see from the slide the way the ventilation distribution works. These are our enemies, obviously, that we're trying to reduce. I think most buildings, and especially old government buildings and DoD buildings, unfortunately, are still stuck anywhere from one to even less than one air exchanges per hour. Of course, if you have a half an air exchange per hour, that's 2 hours before the air in the room is exchanged. I think there's plenty of evidence, including recent studies, especially out of Asia, where entire apartment buildings became super spreader events. I think there's questions whether the MERV 13 filters, which are approved by ASHRAE and Public Health Institute's story, like Harvard, would like to see those. Of course, they put a drag on the ventilation system and their energy increase, but they're rated to 0.3 microns. I think everyone in the panel is familiar that the coronavirus family viruses are about 0.12 micron. So when I'm talking to, again, individuals who would like to see this virus tackled with synergistic mechanisms or adjunctive mechanisms, whether that be dry hydrogen peroxide molecules, whether that be ionization, whether you're going to plug something in or use far UVC, even if you could consider it safe, if you're going to want to tackle, put it in, and kill virus with it, I think you look at the fact that some of these viral particles are moving through the MERV 13 filters, and also, like Scott said, imagine you're not wearing a mask. Can you give the building itself an immune system? And of course, again, we all know that the immune system uses reactive ion species and hydrogen peroxide molecules with its own innate immune system to attack these organisms. And so if you look at the coronavirus and you were to cut a human hair in half and look across its diameter, it's about 100 microns. And at 0.12 microns, just across its diameter, you would have 1,000 virus particles. And so if you took that diameter of hair and imagine those virus particles are like dandelions and you blow on them, I think now that, again, probably Nick and Mary would also agree that you could imagine not in the wet droplet nuclei of the spittle and when we cough in large droplets that we thought were transmitted similar to other organisms that were pathogens. This is actually aerosolized, meaning that these tiny virus particles are individually moving through the air, around shields, potentially through the HVAC, and as little as one, we don't really know the infectious dose, and that could be dependent on other clinical things like vitamin D status, age, immunocompromisation. So what can you do to kill it before it gets to your respiratory tract? And so at Georgetown, Walter Reed, with my colleague out at University of Arizona, we have one of the first true clinical in vivo studies. Of course, it's hard to blind, where we're looking at control versus technology of instituting hydrogen peroxide, dry hydrogen peroxide, or hydrogen peroxide molecules, and reducing hospital-acquired infections. And so I think this is where the rubber hits the road. We have to be able to look years out, apply these new technologies, and actually look to see if it reduces infection versus just looking at independent labs and seeing if the ions we're making can kill the virus. And I think safety and efficacy is where we are. And I think it's exciting that we're having the panels to see, because still I think right now everyone's stuck with masks, open the windows and ventilation. And the hesitancy still is that these technologies haven't moved from the lab or the hospital into occupied spaces like here in the Kennedy Center and art galleries, museums, places where we all like to return to. So I look forward to getting those clinical studies across the board.
Awesome. Thank you, Dr. Cummins and Dr. Call. Maybe we'll stay with you guys here because you made some like really great points. And I think that the key here is, the guidelines, typically guidelines fall a little bit behind the technology. And in the case of the pandemic, we kind of are moving faster than we've ever moved in this space. And so maybe you can talk a little bit about the part, when you were thinking about implementing some of these technologies in critical spaces, especially with the dry hydrogen peroxide, as you were looking at bipolar ionization, photocatalytic oxidation, even upper room UV, it looks like you evaluated all of these technologies. You landed on dry hydrogen peroxide. How maybe you can talk to us a little bit about what it was like as you adopted these technologies. What was the process like? How was it like to deploy it? What about educating your fellow employees, your staff, your patients, on how they're working? Like, how did you guys go about sort of convincing people that we needed to do more? Maybe let's go back to Dr. Cummins and then wrap up with Dr. Call on this one.
The first thing I did actually was I brought the scientific information about the dry hydrogen peroxide to my former colleagues at the White House Medical Unit, who are part of the White House COVID task force. One of the very interesting things that I got to participate in is a continuous back and forth over several days of more scientific data from the creator of the dry hydrogen peroxide system. So it was kind of very neat to see that the White House COVID task force was doing a lot of due diligence to review the science and to kind of fully understand how the dry hydrogen peroxide works. On top of that, during that time, and Dr. Khan kind of mentioned to it, so you can laugh at me, but I went into LinkedIn. I found Dr. Chad Khan. And he called me about 15 minutes later. And I was like, wow, that's so amazing. And we had a long conversation. I sent him a lot of the scientific data. And then one of the kind of very cool parts of this is just watching Dr. Call, who never knew about this technology, do a large extent of review of the technology and all the scientific data about this. So where I'm going, as we're talking about barriers, I would say the challenge of the barriers is what I've seen is the consumers, the purchasers of the system to know, does this actually work? Well, even when somebody's provided the scientific data, they still kind of want some kind of full understanding of how it works. And so what I have seen has been done is people will come in prior to the installation. They'll come in and do air samples and surface samples, and to get to see where things are at in the facility. What are the levels of viruses and germs are prior to installation of the system. After that, the system is installed, and then they come back about 2 to 3 weeks after that to kind of redo the airborne and surface samples to provide that to the consumer so they kind of fully understand that, oh man, this actually works. The other barrier, so basically the barrier is, how does somebody know it works? So providing the airborne and surface data is one way that I'd say we crossed the barrier. And the second thing is odor. Believe it or not, one of the side effects of this is that it does kill odor. So that's kind of the one way that kind of people say, it's working without seeing the scientific data with them. So the other barrier, and we've had several conversations about the hospitals. One of my concerns or one of my thoughts about the barriers of the hospital is the focus on patients having hospital-borne infections? Well, I think that we need to change or add another focus, and that's the focus of employee safety. Based on my residence in occupational medicine, that was really my focus, protecting employees. And with an airborne infection like COVID, actually the staff, I think, is placed at a fairly high risk. But it's a little bit, the dry hydrogen peroxide is currently operating in hospitals, but again, I think we need to kind of refocus for the protection of hospital workers. Similar that I think there's a little bit of focus change on teachers and individuals who work in the schools versus just student sick days. Thank you.
Yeah, and I think to piggyback on what Scott is saying, I think I have a little more broad implementation and exposure as someone studying it at a clinical level and deploying it and have watched the technology get implemented across a wide range of clinical occupational spectrums. Having had deployed the technology, saw COVID patients in and around the dry hydrogen peroxide molecular distribution units being plugged in, testing and having someone COVID standing right in front of me who's symptomatic, and then having dozens of people in a 1,000 square foot area that are very key personnel, the highest levels of government. They're obviously concerned with clinical transmission. Now, again, this is, do you believe what you see or see what you believe? And I'm, trying to believe what we see with the data. And unfortunately, clinical anecdotes are really all you have. And say, just last week on a submarine, there were 30 Marines exposed. It was pure community spread. So we know that close quarters, even young people can transmit the virus. We're doing sentinel screening. So these individuals are testing positive still. So in the areas, in several areas where we have this particular technology deployed, I have seen zero community spread after positive cases. Now, again, we're collecting that information and trying to transmit colony forming unit or microbial reduction and transmit that to, again, an in vivo study to say, did we really stop that virus particle from getting to that person? It will be a very long time before we can prove that. I think that, again, you can draw conclusions and you should do everything up to that point in addition to adding these adjunct technologies. But it does appear promising. And it also appears that my particular concern, like Scott's in occupational health, are at the border. We have thousands of undocumented children with COVID. These technologies that we know reduce volatile organic compounds, we know that we can see in the independent graft studies that it kills enveloped and non-enveloped viruses. We know from thousands of studies looking across the FDA at the OSHA requirements for what the safe level of parts per billion, hydrogen peroxide being 1,000 parts per billion, this being somewhere around 15, which is much lower than what it exists in the lung. And then on top of that, having had deployed microbial UVC, which of course is the ultraviolet spectrum that humans cannot be around, we've also implemented that into spaces clinically that I think that it, like Scott said earlier, that virus has to go from your mouth or your nose, taken up into the HVAC. There's a Bernoulli physics function of how long that virus has to be exposed to that wavelength of light. It may pass by a couple of times before it dies. So again, is there no reason why you can't have an inexpensive microbial UVC with your no touch and your mask, and then also potentially deploy these technologies and then collect data to see if you improve the wellness of your building and improve the outcomes of your patients, and see if they have outcomes that improved return to work and loss of work days. So I think the question isn't do they work and are they safe? It's, is it the right technology for the space, for the cost. And again, when these sensitive spaces where we can't afford to have a large outbreak, even here we're exploring homeless shelters with the Bowser administration on, and how quickly that virus in an uncontained mechanism where individuals don't have masks or access to hand sanitizer or antibiotics, how quickly that could spiral out of control. I think we're going to get a lot of data from that very quickly. So it's been great to be part of it.
But Dr. Call, you talked a lot about these sort of these spaces that are more high risk, and maybe what we can do is shift to Don Gamera here. Don, you've had a number of years working with different technologies that supplement manual cleaning in your healthcare facility. Talk about a situation where you've got healthy patients, you've got patients that are maybe contagious, you've got everything from an operating room to an ER to a waiting room with very different requirements. Maybe you can briefly discuss what the CDC guidelines are saying regarding the use of these technologies, and maybe talk about how they fit into your facility's sort of comprehensive infection prevention and control approach.
Hello, everyone. Thank you for having me today. So I was just going to also on the discussions that Dr. Cummins and Dr. Call had said earlier. CDC currently does not specifically provide recommendations for or against any or the use of adjunctive or supplemental technology. Sometimes CDC would refer to this technology as part of engineering or environmental controls, as that in the prevention of TB transmission. However, CDC does recognize that there is a growing number of technologies out there. So what they have provided are some guiding questions to take into account when you are looking at adjunct or supplemental technologies. So some of these have been addressed actually by Dr. Call and Cummins earlier. First question is, are there any independent studies that prove the desired performance of the technology? You have to rely on what is the available evidence right now, and what, if you're looking at a particular technology, what does the data tell you in terms of effectiveness? And also, when you're looking at this, you have to take into account that the study environments in this evidence represent the environment or the intended use for the technology. So, for example, what Dr. Cummins had mentioned, they have used this technology. They've used dry hydrogen peroxide because of the need and for their space, and be able to deploy it in various places. And I think they mentioned earlier about some older buildings that may not have the appropriate ventilation or increased ventilation for that matter. Also, you have to take into account has the results been published in scientific or medical journal. And I think this is a barrier at this point, because as you all know, when COVID struck last year, evidence is evolving. We learn more about the virus every single day, particularly that first 3 or 4 months of the pandemic last year. So as we learn more about the virus, we also learn more on how we can prevent transmission spread. And also, I think it was addressed, which is really as equally as important, not just from an effectiveness standpoint, is the technology safe? Are there any potential health effects or occupational exposure? And the other question is in here is on where the technology is being used. So some of the adjunctive technologies sometimes are very limited in its scope and you can only use them on space that are not occupied. Some are you can use on a space that are currently occupied. The CDC had provided an approach to the non-healthcare sector, and that is to develop a plan where what needs to be cleaned and whether these are occupied or unoccupied spaces, how the areas will be disinfected, and what are the resources needed. So part of the plan is really assessing your needs and where your highest risk of transmission for that matter. So as we open up more businesses right now and schools, you're gonna have more occupied spaces. So if we're thinking about cleaning and disinfection, you need to think about, okay, how am I gonna clean those? What is my plan? Do I clean them every time an individual leaves the space, or is there ways that I can clean it well and at the same time had other measures in place like the use of supplemental technology? And of course, you have to implement what you have planned. And this is another area sometimes where it is a challenge, not only in healthcare but out in the community as well. And CDC addresses this in their recommendation or in their guidance, such as making sure that you clean visibly soiled surfaces, use the appropriate disinfectant, and follow the directions of use. In healthcare facilities, there are multiple studies that had shown that manual cleaning alone and is not adequate. There are studies that it tells us that it's only about 40 to 50% of the surfaces are cleaned thoroughly by our housekeeping staff. And part of that may be because of the variations among how they clean the space, how they were trained, and talking about disinfectant, did we apply disinfectants properly? So if you're looking about spaces in non-healthcare, you're talking about disinfectants, particularly in schools, the recommendation is to make sure you use the disinfectant away from the presence of children. So how are we going to clean the space? How often do we have to clean it? So those are some of the things that you have to take into account. And again, as we learn more about what is going on with the virus, we try to revise our plan and making sure that we address issues as they come along. So, and this is where actually the role of adjunct or supplemental technologies will come to play. Um, Dr. Colin comments also address the ventilation requirements. And under the current CDC recommendation in terms of ventilations in buildings, SARS-CoV-2 is spread high risk indoors than outdoors, and I think Dr. Phil had mentioned that earlier. And really, the approach is we have to implement a layered approach in terms of our strategies and masking, social distancing, making sure that we clean the space and we check the functions of our ventilation systems. So some of the things that they have suggested is that we increase the outdoor ventilation, increase air, fresh air coming in by opening windows and doors, decrease occupancy. I know that was the challenge for the school system. Most of our kids were not on site in school. They were at home and distance learning because we're trying to decrease the occupancy. But how are we going to do that now? Increase airflow to occupied spaces when possible. Ensure ventilation systems operate properly and improve central air filtration systems. Inspect and maintain your local exhaust and ventilation. I think Dr. Carl mentioned also that there are some energy cost issues when you're trying to increase the flow of fresh air into the space. So CDC does recognize that there are some a potential supplemental approach that you can do in order to improve ventilation. Some of these things that they mentioned are the use of portable HEPA filters, of course, the ultraviolet germicidal irradiation units or UVGI, and dry hydrogen peroxide devices.
Excellent, Don. Thank you for that. That's a great summary. Um, you know, Don, you've also got a very varied history. Every time I read what you guys have done, it's like I feel like an underachiever. But Don, just to give our audience a little background, you've served as the International Epidemiology Coordinator in the Department of Infectious Diseases, um, at, in the International Outreach Division at St. Jude's Children's Research Hospital. In that role, you created an infection prevention training program for St. Jude partner institutions, and you were also the director of infection prevention at a children's hospital, and acted as an advisor to the, and I'm going to not get it right, but I'm going to do my best. All Spanish-speaking people, please forgive me. The Unidad Nacional de Oncología Pediátrica, Guatemala's National Pediatric Oncology Hospital. So you have got this wealth of experience on the importance of safety and how critical it is when choosing a technology, especially when you're exposed to children. And in your particular case, man, children with critical diseases. So maybe you can talk a little bit about the safety implications of some of these technologies, and what people need to take into account.
Yeah, thank you for your question. I am proud to be part of the work at St. Jude in helping them develop and implement infection prevention programs and training key clinical staff in infection prevention and control in line with CDC and WHO recommendations. St. Jude has a global division right now that really helps sites abroad to improve the care of cancer for those children who have cancer. So I am grateful for that program. As you all know, children with cancer is high risk of infection because of their immunocompromised state. So having a robust, effective infection prevention program is critical in the care and management of these children. And as what you have alluded, safety is in the heart of what we do in infection prevention. When looking at supplemental cleaning technologies, the question that always comes to mind, aside from the obvious question whether it is effective, is it safe? Particularly in the presence of kids who are considered a vulnerable population. Um, while an adjunct technologies or supplemental technologies are effective, a number of these technologies can only be used in non-occupied spaces. And additionally, some of these technologies can produce ozones that can cause untoward health effects on people. And in children, it can cause some issues with able to have difficulty of breathing or respiratory problems, even in healthy adults or healthy people for that matter. So a recently published article that used dry hydrogen peroxide, it was done at UNOP, which is the National Pediatric Oncology Center in Guatemala. Um, UNOP is a St. Jude partner site. And in here, what they have done is they have studied the use of dry hydrogen peroxide as an adjunct to their routine cleaning and disinfection of the space. What really impressed me and what I appreciate about this paper is that it did not only address the dry hydrogen peroxide was effective in reducing microbial contamination levels in the environmental spaces and in the air, but the technology was safe and it did not cause any adverse events among patients while the technology was used continuously in the background. And what is impressive about this facility is that uh, they have seen further reduction in the bioburden in spite of their high cleaning quality scores. So usually at this hospital, after they clean the space, they would conduct some surface swabs rather, and to determine how effective was the cleaning and how much bioburden is still in the surface. The baseline numbers were very low to begin with, but they were able to reduce that risk further when they deploy the dry hydrogen peroxide system at the space. So the unit was clean, and the technology added value of for everyone.
Awesome. Thank you so much, Don. This is super helpful. Maybe let's wrap up how we started. Let's go back to Dr. Highsmith, and just maybe wrap up with where we are now. The vaccinations are coming along, not just in the U.S. but globally. We can hopefully, especially with the most recent bill being passed, anticipate a high vaccination rate, maybe some level of herd immunity by the end of this year. Fingers crossed. Do you still believe these adjunctive technologies represent a good investment long term? And if so, kind of why are you thinking that?
Yeah, no, that's a really great question. So obviously very excited about the vaccines coming out, and so excited to start to see that expand in the community as we move to, right now we're doing our individuals with chronic health conditions and that sort of thing. So eager to see how the herd immunity develops. A lot of factors that go into that. I think it's important that we continue to look at these technologies because, ultimately, COVID-19, that's what we're talking about right now, and that's what we've been talking about for a year. But, a year and a half ago, we didn't think we were going to have this. If we knew that sort of thing ahead of time, we could have done things differently. But I think that looking ahead, preparing, always being prepared for the next event is important. And I think that these technologies can help with that. I also think that just with the day-to-day within the hospital setting and the healthcare setting, just the day-to-day cleaning and augmenting the cleaning techniques and anything that will help that is important. We know we have multi-drug resistant organisms. Those aren't going anywhere anytime soon, unfortunately. And once COVID is over and we start to focus back on a little bit harder, on some of the things that we've taken our eye off of over the last year a little bit. I think that looking at these new technologies is very important because there is always going to be a need for that going forward.
Awesome. Thank you so much. And even without the next thing, right? Like the more that we can do and the more we can actually advance these technologies, even to fight, the common cold and this not fight it, but fight the transmission of the common cold and our seasonal flu. All of these things are things we've come to live with. And I think there's just a huge opportunity to reduce the risk of even those transmissions as we move forward. And I think by focusing on these types of technologies, the science will advance, the tech will advance, and we'll get better and better over time and hopefully really make these indoor spaces a lot safer. Thank you so much. And thank you to all of our distinguished speakers for taking the time to speak with us. I know you guys have a little bit on your plate right now. So we appreciate you taking time out of your busy day to spend with us, to help us really educate our listeners and our market on this stuff. You guys live it every day. And the more that we can help bring up the education level of the market on this, the more we're gonna make really great choices. Everyone talked about this. This is a very dynamic situation, and everyone's efforts are really helping us move forward to advance the science around airborne transmission of pathogens. For our part, to bring clarity and deliver science-based data-driven recommendations to our customers, we underwent almost a year-long journey to perform independent third-party testing on a variety of mitigation technologies against multiple types of contaminants. We talked about SARS-CoV-2 here. We also test against bacteria. Staph infections are still a thing. We test against VOCs, particulate matter, all of those things that we consider vectors. We looked at multiple types of mitigation technologies, both in-room standalone technologies like we talked about here, but also scenarios where technologies can be used in the system or in the duct. And to be fair, as we've gone through these, we can't evaluate every product, but we try to do representative technologies. We did find that the dry hydrogen peroxide technology was really the only one we tested that demonstrated efficacy in both airborne and on surface reductions. It reduces VOCs and that odor. So, and we did it by simulating the conditions of traditional commercial spaces, large rooms, air changes that are commensurate with what you would see in a traditional commercial space. We will continue to evaluate emerging technologies in this space because we genuinely believe that the safety and the support of high quality indoor environments is what we need to get to as an industry. And so we'll continue to update our strategies by using unbiased and science-based approaches. While amplified by the pandemic, the conversation around indoor air quality, we believe, is here to stay. And an effective indoor air quality or IAQ strategy is an important part of bringing people back into the spaces in which they work, in which they learn, and for their overall wellness. In the end, every situation is unique, and a thorough IAQ assessment, and you heard this over and over again, assess the situation you're in. We always recommend making sure that you understand the situation, understand the requirements of that space, and develop a strategy or a scenario that works for the space, that is practical for the situation you need. Once a mitigation approach is selected, it's also critical to have ongoing monitoring and management of the air quality, to ensure that maintenance procedures are followed. Again, it doesn't help if we just put in a mitigation approach and then sort of let it ride. We have to make sure that it's continuing to work as the need of the space changes and throughout the life cycle of the building and the space. Thank you all again for joining us here. And if there's any additional question, please feel free to reach out to learn more about our findings or on Trane Technologies findings, or to hear this webinar or engage in an IAQ assessment. Please visit trane.com/Wellsphere and look for a follow-up email after this event. Thank you for your time and attention and for joining us today. And thank you to our panelists. Have a great rest of your day, guys.